morning. So I'm Dr. Gajanan from Apollo Gleneagles, Kolkata, and today with us we have Dr. Puneeta Tandon from University of Alberta Gastroenterology Department. So good morning, ma'am.
Good morning.
So the topic we are discussing today is on sarcopenia, and ma'am, your area of interest is cirrhosis, and you have plenty of work in sarcopenia, exercise, nutrition. So how do you correlate all the cirrhosis patients who have the sarcopenia? What is the number you see at, and how many percentage do you feel that you have over your center, and how do you see that the Indian data differs from it?
Yeah, it's a really good questions. The prevalence, we've looked at sarcopenia based on CT scan in our population.
Okay.
And it generally in the North American population, we're looking at about 30 to 50%.
Okay, ma'am.
Obviously more in males than in females.
Yes.
Now, how it compares to the Indian population, that's a tricky question, right? And because you need to really think about the prevalence is dependent upon what are the cutoffs that you're using to define sarcopenia, and then what is the population that you're really studying.
Okay.
And so that's where I think the challenge comes in directly comparing if you don't have local cutoffs for the population. There was done by Jaya with Dr. Saren's group, and so what Jaya Benjamin, yes, and so what she did is she looked at the cutoffs, the North American cutoffs in the Indian population, and she found that it was about, if she used the North American cutoff, 70% of the people would be classified as being sarcopenic.
So,
whereas she used her own control cutoffs from the local population, and it was less than 20%.
So we say 30 to 50 in the Western population, and 70%, that's the studies we have to compare.
70% if you use those cutoffs, but I don't think that is necessarily the correct way to do it.
So we have to set our own cutoffs.
I think ethnicity is such a major driver of what your muscle mass. Yeah.
So another important question, that if we're talking about ethnicity, when we have studies of the Western data, do we subclassify them as those who are from the Asian group? There might be few patients who are there from the Asian population.
Yeah.
So has the data been looked at it, that how many of the Asian population, because that can also be a bias for the Western studies.
Exactly. Yeah, I think we need to do better on that. I think we need to do, definitely we already subclassify by gender, right?
Yes.
There's gender specific cutoffs, but looking at things like ethnicity and looking at age, those need to be definitely part of the mix if we're going to do this accurately.
When we talk about cutoffs, we know that there are different parameters. Like even if we talk about the psoas muscle or the L3 skeletal muscle index, so these two are also differing. If we go by the psoas muscle of the patient, he might be sarcopenic.
Yeah.
But by the L3 skeletal muscle index, he might not be a sarcopenic.
Yeah.
So how do you see that? Which one is the better one, or we still don't have an answer that which one should we use as a gold standard?
Yeah. So I mean, what different investigators are trying to do by using the psoas is to get something that's easier to use, because it's just a single small muscle, as opposed to doing the entire cross-sectional area at the third lumbar, which is that skeletal muscle index is really the one that's been most strongly validated. But if you look at the studies that have looked at psoas, by themselves, they are definitely prognostic. So it predicts mortality. But there have been now a few studies that have actually compared the two, the psoas
and the L3SMI.
And the L3SMI. And the L3SMI classifies people better. So you might misclassify maybe even 66% of patients. Yeah.
So is it that the L3SMI takes more number of muscles?
Yeah.
So obviously it will be so that goes with the logic.
That, and the way that it was chosen was because it is more reflective of your total body muscle mass.
So would you suggest that if the differentiation is so much that we should rather not use psoas muscle cutoffs and we should always use L3SMI? Because L3SMI, what I know, requires a software to calculate all that. So that software might not be at all the places.
Yeah, so I think as with all of these measures, it's really going to depend upon your purpose for using it and whether or not you're using it for research, and you really need to see those very discrete changes and accurate precision, you know.
Then it is better to work.
So if all you have is accessible for the psoas, use the psoas, but use it with your local cutoffs ideally again.
As you're saying about the muscle mass we are discussing, how do you see that, how better is the muscle function assessment and how should we do it? And does the muscle function assessment really correlates with the muscle mass?
Yeah, so there is a correlation.
Yes.
Muscle function, I guess, can be looking at the strength, or it can be looking
Yes.
at overall performance as well. So looking at things like frailty, for example, right? But muscle strength, I would say the classic test that we would typically do is hand grip strength.
Hand grip dynamometer
is probably the most
yes.
commonly evaluated
and
one.
most easily available. So the hand grip dynamometer we can get for $2,000 from 2,000 rupees from Amazon.
Yeah.
And we can assess the muscle strength.
Yeah. Yeah, so you can use other tests. You can use lower extremity strength. You can use respiratory, like the peak expiratory flow. So you can use those different strength tests as well, and those correlate. Hand grip strength does correlate even with lower extremity strength, and there is a correlation with mass. Many people would say that strength is actually more sensitive than mass.
Then mass. Oh.
It deteriorates more quickly.
But if we talk about any hospitalized patient, like a cirrhotic patient comes to me, comes for, say, acute gastroenteritis.
Yeah.
And at that time I evaluate him. So the muscle function will be dependable on his general condition. That he's not feeling well, he could not do good.
Exactly.
So
yeah,
that way is, I think muscle mass would be more specific.
Exactly. And I think how you have to look at these is that you have a toolkit of different tools that you can use in different situations. So perhaps your sarcopenia assessment, if we're looking at mass, might be a better test to use in that situation. But then these things are dynamic, so they're going to change with time. So you have to remember that as well. So the best thing would be to continue to monitor these things over time, not just one static assessment.
So you feel that each patient should have a follow-up chart? Like
totally. That would be our best way of using it, because let's say you're somebody who likes to really exercise and you eat a lot of protein and you're taking care of yourself, right? Whereas I maybe don't do that. So naturally my muscle mass maybe won't be as changing over time as yours will. How are we going to capture that on one measurement, or ethnicity or age? All of these things, if you can compare within one person, that's ideal.
Other than the muscle hand grip dynamometer, what other methods do you suggest, like tricep skin fold thickness, the mid-arm circumference? These are the basic methods. So are they as good as the hand grip dynamometer, or they should again be just as supportive to the toolkit?
So those things that you're talking about, like mid-arm muscle circumference, is more of a mass measurement, right? Yes. And there is definitely concerns around inter-observer variability with mid-arm muscle circumference, because you're using tricep skin fold thickness and you're using this measurement here, so you're dependent upon the observer.
So how much you pick up the
how much you pick it up, where do you put it exactly? It really depends upon.
So it should be done by a same person if he's referring to different patients, not by different. If you're doing a particular study, the person who is examined should be the same.
Or you have a really good training manual and you know how to do those things. So you can use, obviously for muscle mass, you can use these anthropometric measurements. We've talked about the CT scan measurements you can use. BIA and DEXA are available as well, but they're somewhat challenging in our patients with the volume, right? And then ultrasound, we've done some work looking at ultrasound of the thigh. If that takes off and is validated.
So during the ultrasound of the thigh, which muscle do we focus at?
It's the vastus and the large muscle of the thigh. You just go from the femur up to the top where the subcutaneous tissue is.
The thickness?
There's different ways of doing it. So in the ICU population, what they've done is really cross-sectional area. Thickness is another way of doing it. That's not as sensitive, I don't think.
The cross-sectional area is more sensitive.
Is better. But we haven't studied that yet in the cirrhosis population. It requires a special ultrasound machine.
So is the reason that this will be affected late, other than the other muscles, that whether this psoas muscle, rather the thigh muscles affect quite late than the psoas muscle? or is it just the availability that ultrasound will be less radiation exposures?
Availability, that it will be less radiation. You can do it in your clinic. I think ultrasound is going to take off in general. I don't know if you use it.
So there are any studies comparing the ultrasound, the thigh with the CT cross-sectional areas?
Yes, we've done that, and it was actually quite a really good correlation.
Quite,
yeah.
That's news.
Like a rock of 0.8 area under the rock, so it was quite good. But it needs to be validated clearly, and again, the technique needs to be perfected.
In the pathogenesis in basically cirrhosis patients, what do you feel, ma'am, is the main contributing factor? Is it the nutrition which they don't have? Is it the underlying disease? Or what all factors do you think that leads to the sarcopenia in the cirrhosis particularly?
There's so many factors. You've mentioned a few of them.
Yes.
It's also a really sedentary lifestyle. We know these patients are 76% of their time is spent sedentary, their waking time, right? So they are really, really deconditioned, and then they have poor nutritional intake. Ammonia, we know, is myotoxic. So there's many contributors. Testosterone.
So now from these contributing factors, what would you suggest that for a patient with sarcopenia and cirrhosis, how do you think that the sarcopenia will affect the prognosis? And at the same time, how will you advise that this patient, if does these things, will have a better prognosis? Can we change?
So I think the key is keeping it in your mind that you need to pick these patients up early, because from frailty studies and geriatric populations and other things, we know that the earlier you can intervene, the more likely you are to be able to change things. So don't wait until they are really sarcopenic and really, really frail. Start early in everybody. It definitely is an independent predictor of prognosis, almost no matter how you measure it. So independent of our classical prognostic indicators like the MELD score. And then as far as intervening, I mean, the basics are going to be good nutrition, so protein 1.2 to 1.5 grams per kilogram per day, your caloric intake, making sure that you address their barriers to nutritional intake. If you have a dietitian and you have an exercise specialist who can see the patient, that's key. And then getting them on some sort of an activity program to, especially with resistance exercises, but also aerobic to maintain their endurance. And then pharmacological therapies are coming, but things like testosterone, for example, or, things that will eventually come, like maybe myostatin related drugs.
Regarding late night snacks?
Yes, essential late night snacks, very important. That also, yeah.
So as we're discussing, MELD sarcopenia, how do you look at it as a prognostic marker? Combining MELD score with the sarcopenia. Now, there are a few studies which we have that it tells regarding the morbidity and mortality. How do you look at it?
For me, I think sarcopenia or frailty or any other of these measures of muscle health are really important to be able to pick up that high-risk patient that needs more attention and ideally needs more attention soon. So you can use it to prognosticate. We know it, like I said, independently predicts mortality, but it also predicts morbidity in these people. So who's going to come into hospital? Who's going to stay longer in hospital? Who's going to go to the ICU? Costs of care are going to be double. So it really helps you to pick up that patient that needs help. Okay? And the studies, you're right, have combined MELD sarcopenia in a score, variable as far as how much sarcopenia adds to the MELD score, depending upon, there was one study done from our center, another study done in the Netherlands, found sort of opposite results. But I think the majority of the studies have said that sarcopenia is a very robust prognostic indicator.
Now finally, I would ask to like that, I've also seen that you have many research going on regarding yoga, meditation. So how do you correlate and how do you advise your patient regarding this? Yoga, meditation, and plus the medications. How do you first feel that it will help the patient? And secondly, how do you convey it to your patients?
So good questions. I'm a strong believer in that, in yoga and meditation, just because of the not having a chronic disease. Life is just stressful in general, right? There's so many things that come up. So anything that you can do to try and be in a more balanced state, that's very helpful. So imagine for our patients who are going through so many stresses, it's very helpful even just to give them simple breathing practices like diaphragmatic breathing. so simple and so powerful.
The mind talks to the body.
The mind talks to
So
the
that's
body.
what I read
Yeah.
about.
So right now I haven't done it in cirrhosis patients. Bajaj actually did a study looking at mindfulness in caregivers and found that it was very useful for them to try and reduce their stress levels.
Stress.
Yeah, but I think it's going to be an integral part, integrating.
And conveying it to the patients.
Yeah, you ask them whether they're stressed, whether they have stress, and whether they would like
then
something
we focus it, okay.
to try and help that. And they're very open to it, actually, especially if it's simple breathing exercises.
So, thank you, ma'am, for being here. So it was a pleasure for us to have a conversation with you. And I would like to thank my team for recording such a great video. Thank you.
Thank you.